Welcome to this town hall for the School of Medicine. This would be an unusual town hall, even if there was nothing else going on in the world. But we're having it because of some unusual things. 8 days ago, particularly 9 days ago, we knew that the coronavirus, COVID-19, was going to come to New Orleans, but we didn't have a confirmed case. 8 days ago, on a Monday, we had our first case. Tulane faculty and residence fellows were involved in that case. And we've been involved in many cases since then. And obviously, it's a lot, New Orleans has joined this crisis. So 8 days ago, one case. Last Friday, we had 36 cases. This morning on the NOLA website and the Louisiana Public Health website, we had 171 cases and 4 deaths. And Louisiana moved up to be the number 6 state in terms of the number of cases, despite our relatively small population. You know, it's obviously alarming, both regionally and nationally. I do want to have some perspective because all of the attention and all of the things that we're having to do raises the anxiety level of everyone, and having anxious people around you raises the anxiety even further. So that can become somewhat of a vicious cycle, and is not particularly useful. I must say that here at Tulane, we're really very well positioned in a number of ways. As you'll hear more about, you know, we have some of the world's expert in teaching, in research, obviously in teaching, but also in research regarding viral illnesses. And we also have some extraordinary clinicians. Compared to, say, community hospitals, we have a small army of both adult and pediatric infectious disease specialists. We have another even more substantial army of intensive care doctors. And we have an even larger group of doctors specializing in hospital medicine and other things that are helping to care for this. And one of the things that's a little bit overwhelming when you're in my perspective is the fact that there is so much activity, and so it's and we're newly organized to help address it. So there is almost to many people, including myself, there's almost information overload. Lots of information about what is changing locally and in the hospitals we serve, the patients we serve clinically. as well as a lot of research is coming out. And fortunately, our investigators are both paying attention to this and acting on it, looking into ways that will help address this. Some of the team is actually setting up to have a Tulane-based testing. The university has also taken some really big steps, and the university has been leading the local area, and in fact has often been a step ahead of many others, maybe a step ahead of where the country is in terms of social isolation, trying to make certain that by keeping our distance, that we minimize the spike in illness that might otherwise occur. So the university has gone, as you know, to the unprecedented step of going to online education. You'll hear more about what's happened with the medical students, although I'm sure some of that will be old news. But old news now means that from this morning. Things are changing pretty rapidly. But I do, in the face of such change, I do want to remind everyone to maintain some degree of watching yourself, not only staying physically well, but trying to keep your level of anxiety under control. If you can't, to talk to others, let others know. Let me tell you a little bit about some of the practical things going on. For the School of Medicine, we have a daily call with much of the leadership in the late afternoons. In the relatively early morning, there's a university call about different things that are going on at the university level. There are updates daily about the hospitals that we serve principally. You know, we are particularly watching what goes on at Tulane Hospital, UMC, and the VA hospital, because those are the adult hospitals where we are predominantly. We have faculty, residents, fellows, and up until yesterday, students at each of those hospitals, quite a number of them, quite a number of each of those categories of people every day. So we get status reports on that. Many others also get status reports. And we have the exact numbers change, but we have more than a dozen patients that are clearly positive in those facilities, spread out over them. And we have a larger number of patients who are likely to be positive. Persons under investigation, meaning they've had tests sent out, but the tests aren't back. Some of those patients, but not all, most are not quite ill, but some of those are quite ill. We know that the community still has people in it that are not ill, but that likely have the virus. That's why we need to be real stewards of this social isolation. The city is now doing that, which we're very grateful that they're doing that. Whether more severe measures will be done, should be done, is under active consideration. One of the things that that we are monitoring is, you know, our faculty and our hospitals are not, you know, they're designed for a certain sort of business and not for a sudden spike in business. So we're trying to collectively, and when I say we for almost everything, it's not me, but it's a lot of the people in the trenches, are trying to anticipate what's going to be the amount of patients in 3 or 4 days. Do we have enough residents, enough faculty, enough ICU beds to take care of those patients? You know, the biggest limitation is probably the you know, that we would worry about is if we don't have enough ICUs and we have enough really sick patients. We are not there by any means at the moment, but we do anticipate the number of patients to grow. We are some time away from the peak. The peak is likely a couple of weeks out. This whole episode of the virus is likely, in terms of at least a couple of months. You know, everybody would like a definitive answer as to when will life get back to normal. It won't be April. I'm hoping it's the summer. But we are planning and will approach this well. Let me go back to some other things that are being done at the hospitals and clinics. We are now in all of the hospitals limiting elective surgery. Now, elective surgery has many forms. Obviously, urgent, emergent surgery is one thing, but elective surgery can be of several types. There can be electives, and I'm not a surgeon, but elective surgery can be that needs to be treated this week or next, but not a month. Well, things may not be better in a month. On the other hand, there is some surgery that is so elective that it can be done 2, 3, 4 months. Screening colonoscopies. The same is true for other types of procedures. So that is purely elective and can be put off is being put off. Our hospital systems are being strained. The clinics, somewhat the same thing. In that routine clinic visits, first we're trying to move them out of Tulane Hospital to limit the strain on Tulane Hospital. The strain from many perspectives, screening all the people that come into the hospital and clinic, the strain in terms of protective devices, There are some clinic visits that need to be done, though, in a timely manner. They can't be put off 2 or 3 months. The most extreme example might be chemotherapy done as an outpatient. Patients need to come in. They'll still come in. Radiation therapy, the same way. And there are other things that people will need, but they are technically clinic visits. We will be moving some things from hospital-based clinics to TUMG-based clinics. This is being rolled out. Patrick Delafontaine is going to help Kim Peters in her work in coordinating with the hospital, Sean Flynn, who leads the hospital-based clinics. There'll be more coming out about that soon. A lot has gone on. At this point, I think I'm going to turn to David Mushat, who is head of adult infectious diseases, is the person that I turn to as the local clinical expert. And Dave's going to give us some update. You need to unmute. He's muted.
Can you hear me now?
Yes, now we can hear you, Dave.
Great, thank you, Lee. Welcome, colleagues. I'm going to run you through some data quickly, just to kind of get everybody up to speed. And as Lee said, it literally changes from hour to hour. I've been on rounds and whatnot, so I actually haven't seen what's come out since this morning. It's a lot of information. It's hard to keep up with it. But on the other hand, there's a lot of different people that are helping on different aspects. So here we go. Let me get this baby rolling here. Okay, so this is the Louisiana data as of 9:30 this morning. It's obviously been updated at 5:30. I haven't had a chance to load that up, but as you can see, there were over 170 cases reported, over 450 tests completed, and 4 deaths. You can see that there are no cases in the center of the state. It's mostly down in the southeast, a little bit up in Shreveport. I'm sure that it will eventually permeate into the interior of Louisiana. One thing to point out is 457 tests is not very much. It's a very slow ramp up at the state level, and no follow theirs. There's only so many tests they can do. It's a complicated process, but there's literally probably thousands of tests that actually need to be done. So the numbers will keep going up. This is some information on the epidemiology worldwide. On the left, you see the total number of confirmed COVID-19 cases through yesterday. It's over 160,000. You can see the exponential increase, and this is almost entirely outside of China. China is having fewer than 20 or 30 cases a day, but everywhere else it's going up. And here you see the daily number of new confirmed cases. It's getting up close to 15,000 cases a day, and that's exponential, if not more steep. Let's talk a little bit about symptoms. The Chinese have done a phenomenal data of tabulating and compiling the data on their experience. Keep in mind, this may or may not be reflected in other parts of the world, but it's based on a lot of patients. As you can see here, 56,000 cases. So the good news is that most people do have fever, but not everybody. So about 90% of people have fever, and I guess that's true of medicine in general, or infectious disease. Most people who should have a fever do, but not everybody does. About 2/3 have a dry cough. That seems to be quite classic, and that goes along with the hypoxemia that they develop. A lot of people have fatigue. About 1/3 have sputum production, shortness of breath, about 19%. That also can be a marker of disease progression. And then you have all the other sort of viral symptoms, such as myalgia, sore throat, diarrhea, maybe a little more common than that, I'm not sure, but sometimes you do get GI stuff, which can fool you because you're thinking of a respiratory illness, but sometimes they will start out with GI symptoms. So this just to kind of give you some sense of what the disease looks like. In terms of fatality rates, case fatality rates on the left, I'm just showing you the association with underlying conditions. Based on the Chinese data, you can see that cardiovascular disease, it was the main risk factor for fatality, but diabetes, chronic respiratory disease, hypertension, cancer, and other things were associated. I wouldn't get too hung up on the relative percentages here. It probably will vary from population to population. You know, early on, there was some thought that perhaps the hypertension was a marker for ACE inhibitor or ARB use, which could upregulate one of the receptors that the virus uses. I don't think it's entirely clear. And my understanding is that in Europe, they're saying you don't necessarily need to stop ACE inhibitors in your patients who have this disease, but you probably don't want to start them. If you look at the case fatality rates by age group, what's remarkable about this infection is that both infection and mortality are very low in the youngest members of our society. You have very few deaths in people under 10 to 20, but you see there's a gradient, and once you start getting in your 40s and 50s, you see an appreciable increase in mortality, and certainly in people 65 and older, the mortality goes up. You can see if you're 80 plus, it's about 15% again. This is based on the data in China, and I suspect it will vary geographically depending on host genetics, perhaps other things such as pollution levels, you know, how many exposures people had, comorbidities, and certainly, you know, it's quite possible that the reason that we're seeing so many sick people in Louisiana is that we have a lot of comorbidities here, whether it's morbid obesity, diabetes, or what have you. This is my favorite chart here. I talked at the meeting about a month ago or a couple weeks ago about the so-called surveillance pyramid. You could also call this the clinical presentation pyramid, and this kind of gives you a sense of how this disease presents. So the good news is that over 80% of people who are diagnosed, at least diagnosed in China, have mild disease, but another 19 or 20% have critical or severe disease, and overall about 2% of people died. So by critical, we mean patients with respiratory failure, septic shock. Severe means that they're in the hospital and often in the ICU. And these are not trivial numbers. And if you just do a back of the napkin calculation, if you had, let's say we have 100,000 infections in Louisiana, which is not impossible, that would still be 5,000 critical cases. That's a lot, especially if it happens over a short period of time. The bottom of the pyramid is going to be all the people who have asymptomatic or very mild disease, and all viral pathogens, have, they have the ability to infect more people than the number of people that actually get sick. And so that's something that will be determined later. What will happen is epidemiologists, scientists will do serologic surveys with, looking at IgM and IgG in the coming year, and we'll get a better sense of how many people truly became infected. And, the thinking is that once that's done, the mortality rate may go down because the denominator will be larger. This is the everybody's favorite curve. This is the curve of number of daily cases. So the left, the yellow peak is the worst case scenario. This would be, without any mitigation measures. And then the purple curve shows the flattening, the so-called flattening of the curve. This is what the Surgeon General has been talking about, and many others, Tony Fauci at the NIH. The idea here is that if we can mitigate this disease, and we'll go over what mitigation means, we can flatten it and we can spread it out so that the capacity of the healthcare system, which you see here with this dotted line, can handle the epidemic better in terms of providing good care, testing, ICU, and ventilator support. If we don't do that, this is what happens, and we completely overwhelm the system. So again, think of this as a way to mitigate the epidemic so that we can handle it more effectively. So what are some mitigation strategies? I break them up into personal and then business and community. So personal, I think we all know about social distancing, keep at least 6 feet from other people when you're in public. Encourage cough etiquette, i.e. coughing into your sleeve or a tissue. frequent hand washing or cleansing. I really don't care if you use soap and water or alcohol, but use something. Try not to touch your face. You may want to wipe down surfaces, doorknobs, etc. And you know what? Stay home, lie low. This is the time to camp out at home as much as possible, because you know what? It's not just about you. It's about everybody else. And we all think that, well, people say I'll travel. I don't care if anything happens to me, but it's not so much you. It's that you may carry the virus to somebody else, so you might bring it back. You need to think of both sides of the equation. In terms of what we can do at the business level and community, again, we're encouraging people to work from home as much as possible, make use of email, texting, Zoom, Skype, and other platforms, avoid in-person meetings, try to Zoom your meetings. And as physicians, I think we can make more use of telemedicine. And I don't just mean the formal, platforms on ECW and things like that. I'm not sure if I'm going to have time to learn how to do that personally. But there's a lot of docs around the country. One of my buddies at the Brigham in Boston, Paul Sachs, sent a tweet yesterday saying how wonderful it is now to get back to calling patients and having a chat, and how effective and reassuring that can actually be. So there's a lot you can do with a simple phone call with your patients. You can use the patient portal emails. A lot of people are contacting me that way. You can use Outlook. If you're worried about security, you can always type in secure in the subject heading. That will encrypt it. And then you can use formal telemedicine using video if you are capable of doing that. Again, this is the time to be creative. And I think that there's a lot of room for improvement in this area. There are a couple of bright spots. The good news is that the first vaccine went into a human yesterday. This is the messenger RNA vaccine phase 1 trial developed by Moderna, which was given to the NIH. And the first dose was given to a person at Kaiser Permanente in Seattle yesterday. This will be an open label trial. About 45 healthy adults will receive this candidate vaccine over 6 weeks. And scientists will be looking at the body's response, looking at antibodies and other surrogates of efficacy. This vaccine, we hope, will express a virus protein that will help elicit a robust immune response. So exciting news. It's probably the fastest, at least, development of a candidate vaccine ever in human history. There are many other candidate vaccines in the works that we'll be hearing about. The heartening thing is that all the medical centers here, VA, UMC, and Tulane, are beginning to fashion treatment algorithms that are, adapting suggestions from other places that have been in the game a little bit longer, such as University of Washington at Seattle, Boston VA, and others. Unfortunately, there's not a lot of data yet, but the Chinese should be close to publishing some data on some of these agents. So some of the things you're going to see in use are chloroquine or hydroxychloroquine, or Plaquenil, which of course is used for lupus patients. There is some thought that this may be beneficial. I know the university has quite a few doses of this, and we're starting to see it used to some extent. The antiviral remdesivir is the Gilead antiviral that is available both through compassionate use as well as through clinical trials. I want to make a shout out to Darlene Fusco here, who's doing a phenomenal job of trying to get one of the Gilead randomized clinical trials here at Tulane or University Hospital. It's not easy to get these things done in a hurry, as you all know, and there's a lot of competition for these things, but we believe that our numbers more than warrant getting access to these agents. There's many other things. I think one of the participants mentioned a drug from Japan, any other antivirals. There's, of course, the question of steroids. The Chinese literature suggests it might be helpful in patients with ARDS. The problem is that, a lot of these reports are anecdotal case series, and, we don't know, particularly with these immunomodulators, whether they will help or make things worse. There's the other, was it Tarisolab? I may have said that wrong, but the drug that inhibits IL-6 looks promising in patients with very severe disease, because there is a now report that some of these people succumb to cytokine storm from the viral infection. My best guess, I'm not a virologist, is that the antivirals will work well early in illness, just as oseltamivir or Tamiflu works well early in flu, but not later. And then after the beginning of the illness, as it progresses, they may play less of a role, and there may be a role then for immunomodulators and other drugs. but I think the timing will be critical, and that's, of course, the tricky part to tease out. And I think that's all I have. Thank you very much.
Thank you very much, David. Very, very useful information. Now I want to turn to Patrick Delafontaine to give us some update about research operations.
Thanks, Lee, and thank you to all for being here at this town hall. This is a critical time for the school and our university and the city, and the role that all of you are playing is really extraordinarily important, and we're all very grateful for everybody's teamwork through this challenge. I know that many of you were here during Hurricane Katrina, and I catch myself occasionally saying or feeling that this feels a little like deja vu, although there's clearly some big differences, one of which, of course, is that this is a national problem, and in fact, not just a national problem, but a global problem. So I did look at some of the questions that were submitted regarding research. I'm just going to make some comments, and I'll try to address some of those. I would refer you to the guidelines around research that were published first on March 12th, that's last Thursday, and then updated yesterday. And I'd also refer you to the guidance document that our Vice President for Research, Dr. Piedimonte, issued on March 14th, last Saturday. Please abide by these guidelines, and in case of questions, contact me or Marla Lamp in the Dean's office. So there have been some questions around the research enterprise and whether it's actually continuing. And let me say up front that research is mission critical for the university, and it absolutely is continuing. Although guidelines have been issued around work conditions, around precautions, we feel that we can safely continue this mission, which is critical for the school and the university. The two-lane research support units are fully operational. As pointed out by Dr. Piedimonte, the IRB, the IACAC, the Department of Comparative Medicine, Biosafety, Office of Research Proposal Development, the Sponsored Projects Administration, are all working. Some of those units have adjusted their operations somewhat, but they are all fully functional. Some of them are, have, for instance, changed their review processes. The IACAC now is doing its review by sending it to one designated member in order to try to speed up the process and be more responsive. And of course, if there's any group meetings, they're all done via video conferencing. They've also eliminated deadlines for protocol submissions in order to facilitate processes. Obviously, all researchers and their teams should take all preventative measures, and those have been outlined. And in fact, Dr. Mushat has just gone through some of those again, but I will reiterate the importance of social distancing, conducting meetings via teleconferencing, and if possible, working from home with approval from their supervisor. Now, in laboratories that do bench research, and that may have groups of folks that may approach 10 or more, we suggest that they stagger the work and that they basically have some folks work earlier in the day and some folks work later in the day. And I know that that is, for instance, what MD Anderson is doing. A word about the IRB. The IRB is fully functioning, is giving high priority to applications relating to COVID-19. We have made some changes to studies that do not have any direct drug or device therapeutic benefit. An example of those studies would be observational studies. One that springs to mind, for instance, is the large NIH study called All of Us, that Tulane is a leader in. That study does not involve any drug or device therapeutic benefit. And so those studies will be put on hold. Recruitment to those studies will be put on hold as from Wednesday at the end of the day. And what we're putting on hold is face-to-face interactions. Remote monitoring and data collection obviously may continue. I'll point out too that for studies that do have face-to-face interactions, that all subjects are being pre-screened before they actually access the research clinic or the clinical trials unit. And the details of those screening measures were included with the announcement that went out last Thursday. As far as ongoing projects and enrollment of new subjects, that can continue, but should obviously be examined on a case-by-case basis depending on the study, but remains largely a decision of the principal investigator of the study. Initiation of new studies can also happen, but are currently being screened through the dean's office. And the only exception to those is studies that involve COVID-19, that are COVID-19 related. A word about some of the support that is being offered by the clinical trials unit. In order to assist researchers that may need to submit amendments either to the Tulane IRB or, for instance, researchers that would need to submit changes to clinicaltrials.gov, they can utilize the CTU resources free of charge. If you need help in those areas, please contact the clinical trials unit at ctu@tulane.edu. So we are in a situation where we are continuing the critical work of the university. Safety is paramount. We encourage everybody to follow safety measures as outlined. And we thank the faculty, the staff, and all the administrators for their dedication, hard work, and selflessness. And I think I'll finish by saying that I think we anticipate there's a lot to do as far as COVID-19, and we anticipate that Tulane will actually be making some of the groundbreaking research advances that will allow us to not only better treat this disease, but actually prevent this disease in the months and the years to come. Thanks, Lee.
Thank you, Patrick. We're now going to sort of switch gears a little bit, and we're going to go through the various academic programs. In the room are Dr. Kevin Crane, the Vice Dean for Academic Affairs, and Dr. Elma Ledoux, the new Associate Dean for Student Affairs and Admissions. Also in the room is, let me give a little shout out to Dr. Mark Kahn, who is departing for the University of Nevada to be their dean, and we owe him such a huge credit of gratitude, but we're also so proud of him. Anyway, we were to have a big celebration, and coronavirus got in the way. Anyway, let me turn it over to Kevin and Elma for a few minutes to talk first about students, then we'll go to residents, and also then graduate students.
Hi, I'm going to start by giving an overview of where we are with our student programs. And like many of us in our positions, want to thank all of the people we work with for the tremendous amount of effort they put into making basically changes at a moment's notice to accommodate and meet with our primary goal, which is to ensure the safety and health of our students, while at the same time maintaining the educational integrity of their programs. So for the students who have not begun their formal clerkships or clinical rotations, I'll run through real quickly. All of their activities, their didactic classroom types of activities, have been moved online. And again, the faculty have very quickly adapted the methodologies of moving to Zoom presentations. We've even done sessions with active learning, case-based learning discussions with smaller groups within a larger framework that we were able to deliver online. Traditional lectures can easily be delivered online, and the faculty have stepped up and done that for particularly the first-year students. For the second-year students, they have finished most of their coursework. They've come to essentially the end of their pre-clinical experiences, and there are several exams that they are participating in, and we made some modifications. So first of all, let me go back to the first-year students. They have an exam coming up next week, which we actually changed the actual date of to accommodate all the activities, but it will be given, as with all the rest of the exams, as online exam through remote access from their homes, wherever their home may be, whether it's still here in the city or some other state, and we'll be administering that through Canvas using online proctoring methods. We're also changing the methodology of some of the exams, both for first and second years, where we are not putting students in a position where they must take certain exams. And so we were able to move one of the exams to a self-assessment process. And so we have modified the way we deliver exams significantly. For those who are familiar with, many of the exams that we administer are done by the National Board of Medical Examiners. At the present time, they still require on-site, very high security with very specific proctoring requirements. We all across the nation as educators are waiting for them to see if they make any changes to the way they administer their exams. At the present time, they haven't, but we are waiting. We've suspended all clinical activities for the first and second year students, which we did last week. We've suspended activities in our standardized patient program, the simulation center, all with the purpose of maintaining safety and health of our students, as well as the rest of the community and everybody who they work with. We can make up some of those activities later. It's not a major challenge. For the clinical students, we made the decision, which clearly was the right one to do, which was we suspended all clinical activities as of yesterday at noon. So all students on any clinical rotation were removed from that setting, and we will continue to deliver all the didactic activities. So whether students are doing surgery, pediatrics, family medicine, whatever it is, we're going to continue the schedule that they currently have, deliver the didactic activities, online, address how we're going to do assessments, which we're actively discussing, but the clinical activities are completely suspended. I know everybody's wondering, how do we make those up? Well, they'll be made up at a later date. There is enough flexibility in the schedule for particularly the third-year students that we probably have a couple months of opportunity to make sure that they can complete these activities. In the meantime, the major educational organizations, particularly the Association of American Medical Colleges, the AAMC, has stepped in and provided some guidance and some guidelines for everybody, and we've been well within those guidelines. The other major organization that also is involved are the accreditation agencies, particularly the LCME, which governs all of us for medical school accreditation. Generally speaking, they require that all students and all schools make sure that students can meet their objectives. And it again, surprisingly leaves a little bit of flexibility in that if necessary, we could shorten clerkships, but at the same time, we want to make sure that the educational integrity is not changed. This means that students cannot complete a surgery clerkship unless they actually participate in surgical activities in the hospital. Because we can't do that at this time, those will be delayed. We'll work out a system for them, and we're developing contingency plans. For many of our fourth-year students, they have actually finished all their activities, and they're essentially waiting for graduation, which is a wonderful thing. On the other hand, we still have some fourth-year students who are completing electives, who are completing clinical activities, which we're going to have to make some adjustments for, and we will address all of these issues specifically. Some of the questions that are coming to us in general are, what's going to happen with the new students starting their clerkships? If that is delayed, we have some flexibility in the schedule, and we will adjust accordingly. Many of these issues, such as when so many of these issues are really national issues, and national organizations are stepping in. The one big wrinkle for many of our students is the second-year students are about to take their USMLE Step 1 examination for licensing, and today the Prometric centers where the exams are administered announced they'll be closing down for a month. I know this is very disappointing, very concerning to many of our students who are studying and planning to take this exam in the immediate future. What I can do is reassure you that your schedules, the activities will be redone in a way that will not interfere with your ability to study for the exam and take it at a later date, which is absolutely going to be what is necessary. We can accommodate you. I will tell you that the clerkship directors and all of us are meeting on a regular basis through our Zoom conferencing, which we've come up to speed very quickly, and we're going to develop significant contingency plans regardless of when activities are pushed back. So we're essentially building the plane as we're flying, but I can promise you the clerkship directors, course directors are meeting on a very regular basis to address all of these concerns for students. At the same time, we've tried very hard, and I'm going to turn things over to Dr. Ledoux in a second, but we tried very hard to provide regular updates to the students, to let them know what we do know, and at times let them know what we don't know and can't find answers to, such as what the National Board of Medical Examiners is going to do. So while there are a lot of unknowns, we know that we can adjust for them. We are the most experienced people in the country, having gone through Katrina, having moved the medical school 350 miles away to Houston and restarted 1 month later, doing things that people thought weren't possible, but we can do it. There's an esprit de corps. We've got incredible faculty, teachers, clerkship directors. They have all doing incredible things to make sure that the quality of everyone's education is maintained under the most difficult of circumstances while protecting our students' safety and health. So I'm going to stop now, and I'm going to turn things over to Dr. Ledoux.
Thank you, Dr. Crane. I'd just like to reiterate Dr. Crane's comments regarding the situation with the students, and to let the students know that this is not unique to New Orleans. We always have to remember this is a nationwide problem, and when all is said and done, a certain degree of flexibility will have to be offered by not only the accrediting bodies, but each individual medical school with respect to the graduation requirements. So while we don't have all the answers now, we will have an equitable ending to this when the time comes. And it's really a unique situation that doesn't have specific light at the end of the tunnel just yet, but we hope within the next month things will become clearer. Just a couple of points. This is match week on Friday, March 20th, nationwide. The senior students, senior medical students, all find out simultaneously where they will be having their residencies next year. This is normally a huge festive celebration at every medical school in the country. However, this year it will be held in a different format. For our Tulane students, we hope to have a smooth transition via email, during which time students will be able to simultaneously open their emails from us coming from the Student Affairs Office, while also watching a video, a festive video that we really will transfer what would have been done at the Hyatt on a small scale through a video to the students. At that point, they would be free to post, working with the student leaders, their own announcements of where they will be attending. So it's certainly not what we would have liked, but I think it'll be fun and memorable. The other issue has to do with student volunteerism. Students volunteer in 22 clinics throughout the city on a regular, as part of their regular coursework and service hours. This, of course, has been curtailed. Students have, in the meantime, raised the issue of whether or not they might be useful at the hospitals or the outpatient clinics doing something not necessarily medical, perhaps even clerical, but useful, since now they have a little more time with classes being delivered via Zoom. And so what I would ask, rather than have students converge upon your hospitals and clinics, what I would ask those of you listening, if you have any particular need that you think medical students could specifically address at your institution or in your emergency department or service line, please communicate with me directly. Just send me an email and we'll then send that out to the students. I think would be a much more organized way to help you out and also allow the students to become involved in this emergency. Thank you.
Now we're going to turn to Bob Gary and Diane Blake discussing graduate students.
Okay, I hope Diane is able to get back on. I think she may have gotten cut off a little bit, but I just want to say a few words and to echo what Dr. Delafontaine said about the importance of the research mission to the university and particularly to the medical center. We are going to make all the accommodations so that the research mission continues, especially as that relates to graduate students and postdocs. So, you know, taking into account all of the issues with social distancing and being safe in your work environment, we will enable the research mission to continue. I should just make one little note that that also includes rotations, which our graduate students always do, and we are going to make those rotations continue after this week and enable students to start rotations you know, after this week is over. So that aspect of the graduate program will go on. Diane, did you make it on? Not sure if she did. I think if she's not able to get back on, I'll just continue then. The classes for the graduate students are, as other classes, going to be online. All the classes, the graduate classes, are going to continue as before, and only except just over the internet. And also things like graduation and particularly dissertation defenses are still going to go on. We're going to restrict, you know, people including the committees from meeting face to face, but that doesn't mean that the student can't present their dissertation work, defend it over these over the internet. So we're going to continue to do that, and hopefully there won't be a disruption in anybody's career path. We're looking forward to accommodating everybody's needs in that regard. So really, Lee and Patrick, that's all I really had to say about that. Unfortunately, Diane Blake, I think, is not able to speak, and so, but those words should suffice.
Thank you, Bob. And Diane, it's conceivable that she's on, but with the technology, sometimes it's difficult to find.
Yeah.
I think
Also,
we have.
in case anybody doesn't know that I have studied viruses a little bit, so in the question period, I'll be happy to, chime in if there's a specific virology question.
Yeah, we actually are going to come back to both you and David. I want to ask a little bit about testing and get a little bit of information from all of you. But before we go to some questions that were sent in, we also have, I think we have Shantae Bolton on the line, and Jason Cretion, who's the interim assistant vice president of HR on the line, I think. And I was hoping that they would say a few words.
Yes, Dr. Hamm, this is Jason Cretion. I'm on the line. Can you all hear me?
Great, Jason.
Well, good afternoon, everybody. Just wanted to drop a couple of quick messages in from the Office of Human Resources. And Dr. Hamm, what you said earlier is this situation and the news that this was this morning's information has changed by this afternoon. And one thing that we've found in the Office of Human Resources and Institutional Equity is that this situation continues to evolve. Where we've largely been focused is in the shifting to the remote work environment, which has been, largely a feat for many individuals within the university, going from a traditionally based office environment to a remote environment. So over the past couple of days, we've been largely focused on ensuring that we're able to support the workforce in that effort. Clearly, this is not a one-size-fits-all situation. There are many nuances that we found throughout this exercise, but we continue to leverage our HR business partners as our resources on the ground, many of whom have been in contacts with administration and representatives throughout all of the schools on the downtown campus. We continue to review, revisit, solve, and solution any of the issues that are brought forward to HR business partners. So the message I wanted to share today is as y'all bump up against issues, reach out to your HR business partners and leverage them as a resource to solve any issues that are presenting to you. We review those issues on a daily basis and are actively triaging and working through those that do present. And I just want to reiterate that we've put out a lot of information, most of which is contained and found upon the University Emergency Preparedness website relative to the COVID-19 FAQs. We continue to update those daily. So always a direct back there as a point of reference. If we didn't capture the answer there, we're about to get it there. Our effort is always to try and get as much information out to you as we possibly can. Thank you.
Thank you. Thank you very much, Jason. We originally were going to ask Noah Wong to speak, and then I thought, well, we're going to be running short of time, but I do see where we could open up the line for Noel, and I was trying to text him an audible to see if he could say a few words, but the IT has been fantastic from my experience. But anyway, I'm going to put him back on, put him on the spot.
It's okay. Can you hear me?
Yes.
Okay, great. We've been working hard to make sure all the technology you need to continue to teach and do research is available to you wherever you are, right? So, of course, Zoom, Canvas, Box, all that are on the internet for your consumption. You don't need to come into Tuning Network for it. So that's available to you today. There might be things that you will need that is on the internal network, like research data on file share, things like that that you may need. In those instances, you will need a VPN client installed on your machine from home. If you go to the IT homepage, which is it.tulane.edu, there's a link right on top that takes you to a page that has everything you ever need from a remote access perspective. So, and all the instructions are in there, all the links are in there. If you need help with Canvas or Zoom, Mike Griffith is on the line as well. He's the leader for the ILC. He's continuing to hold classes around the clock for the next couple of weeks to make sure people are familiar with the technology. Other things that we're doing, we continue to staff up the help desk as the volume increases to make sure that you don't have to wait long for help desk calls. And we're also in the middle of inquiring additional PCs in the event that where the student, the faculty doesn't have a PC at home and you need to have a loaner for some number of weeks. We don't have a large quantity. We order some quantity that's supposed to arrive this Friday. And then there's another shipment coming in the following Friday. If you have that issue, just go ahead and call the help desk and we'll route you through. Other than that, it's business as usual. We're having some problem right now with Banner connecting through the VPN. Short-term why we're handing out virtual desktop to those users just to get by the performance issue. But once we resolve it, we'll be back to normal. That's all I have. Really.
Thank you very much, Noel. Now we're gonna do some questions and answers. Although this is a difficult format to do questions and answers. You know, we're getting some where people are using the chat feature of Zoom, and some of those are so specific that I think they're going to need to be answered by somebody else. We did get some questions sent in beforehand, and I want some of the people that are either on the line or in the room to help us address. One of the big questions has been about testing. One, who should get tested? And maybe David Mushat could talk about that. And then second, when will more tests be available? And I know a lot of people are working on that. I want Bob Gary and Patrick Delafontaine to both weigh in. So David, first you about who should get tested.
Yeah, can you hear me?
Yes, David.
So, I mean, that's a real hot potato, obviously. If we had thousands and thousands of tests, we could test everybody who comes in with a cold, cough, sore throat, et cetera. That would be ideal, but clearly that's not possible. Certainly, anybody who comes into the hospital, into the ER, who needs admission is a high priority. As I recall, a few days ago, the state lab's priority was ICU patients, followed by healthcare workers, followed by general medicine patients, gen surge, and then others. And that was, that was something, but it's a moving target. So bottom line is, if you're super sick, you're more likely to get it. If you are just a little sick and you're at home, ideally I'd love to test you because I would like to be able to counsel you, about quarantine or home care. But the reality is that it's just not feasible right now. I mean, there's a whole host of reasons that we don't have time to go into for why we can't get it. It's going to get better, but it's ramping up slowly. The bottom line is, if you're not very sick, take care of yourself and isolate yourself as best you can. Wash your hands. Don't go out in crowds. There's nothing we need to do for you per se. There's no antiviral or anything like that that's indicated. Most 85% of people are going to get better without any medical assistance. We're all waiting with bated breath for the federal private the testing initiative that's supposed to be coming here this week. I understand there will be drive-throughs in Walmart and other business parking lots. I have heard nothing about that, but certainly the mayor the other day at a press conference said that was going to happen. I believe it will. So there will be more opportunities for anybody to get tested. You do not need to get tested if you have no symptoms, okay? Even if you're a healthcare worker, you do not need to get tested because we don't know what, it's just not a good use of limited resources, and much more likely than not, you will be negative. Now, are there rare cases of asymptomatics who have virus who could be spreading? Yes. I mean, everything is a bell-shaped curve in medicine and biology, or not everything, but most things are. And so there will be exceptions to the rule, but they're probably more exceptions than the rule.
Bob, Gary, and Patrick Delafontaine, is any work going on toward a Tulane test?
I'm going to largely defer this to Bob, but I will say that there's a number of folks that have been meeting and working on looking at accelerating the access to testing, which I think everyone knows is a real problem nationally. We had some high hopes a few days ago when Roche got a test approved, but it turns out that access to that kit is going to be much more difficult than we initially thought. The FDA has changed its processes and now allows development of new tests without an implementation of new tests without the usual regulatory hurdles. And so I think we are going to be looking at developing a test in-house. Dr. Gary is really leading that effort, and I'm going to ask him to just make a few comments about that. That really is a work in progress.
Sure. So, yes, Dean Hamm and Dean Delafontaine asked me to take a look into this. Actually, just this morning, I'm pretty happy to report that we're going to have most of the necessary reagents, the key ones, in tomorrow, and so that we should be able to start working on ramping this test up and validating it. Now, there are still some hurdles that we're going to have to work on internally to actually be running the test here at Tulane. First, we need to get the approval from the state. I don't think that will be a major problem, but we have to do that. And we also have to identify one of several CLIA-approved labs that the test can actually be run in. But up here on the 5th floor of the JBJ, we are going to be making this test happen. I'm quite confident that we can make the test work well.
Thank you, Bob. Patrick, I know that you've begun helping to coordinate about the clinics. Can you comment more about where we're going with clinic visits?
Sure. So I think, as all of you know, there's been an effort ongoing to try to reduce elective procedures at the hospital. as well as reduce routine clinic visits that could be delayed. And I will say that obviously our patients come first, and in some cases, routine visits cannot be delayed, and they will continue. But in the case that they can be delayed by a few weeks, a few months, we are working on trying to implement that. And as part of the strategy around clinics, the school and hospital have decided that they will be moving a large part, not all, but I'd say the majority of hospital clinics will be moved off-site. We have a number of clinic sites, as you all know, outside the hospital, in Metairie, Uptown, and others in the East Jeff building. And so a plan is being put in place and actually will be implemented relatively fast. There'll be a communication coming out about this actually probably tomorrow. And we anticipate that that move will occur by the end of the week. It will actually start tomorrow and will occur by the end of the week, so that by next week, for the most part, outpatients will be seen at these sites. Now, there are some exceptions again. I'm not going to go through those this evening, but there are some exceptions, and in those cases, the clinics will stay in-house here. This work is really being coordinated and implemented by Kim Peters, Jaime Perez, and Sean Flynn on the hospital side, working together. And I'm assisting in planning and coordination of that effort.
Thank you. There are a whole slew of questions, many of which are being put in the chat feature. Again, many of them are difficult to address in this format, and also they scroll up so that you know, you can't see them all at one time. I think what I will encourage you to do, and it goes to, they should be addressed by various people. So I think what we're going to do is I'm going to ask you to email those. We'll send out an email question for you to send those again, and then we will sort them. Respond to that email address, though, and we'll sort them to the appropriate people. We are going to try to have these town hall. I don't know if we'll have them once a week or somewhat periodically. Let me tell you that as easy as a town hall looks, it takes a whole team to put it on, and also I think most of us in leadership, let me say that we are we're getting emails at the rate of about 1 every 30 seconds, so that it's next to impossible to address all of them individually. So we'll try and figure out something. We may put up an FAQ for ones that are appropriate. With that, I think we're going to give you 15 minutes back of your evening. Thank you for participating, but particularly let me thank all of you for your patience, your hard work, your continuing engagement. It's a real honor to work among you. So thank you very much.
Thank you.